Hello, and welcome to Let's Talk SADS Live, Canadian edition. I'm your host, Dr. Shu Sanitani, and delighted to be coming to you from Vancouver, that I have the privilege of calling home. And I know that I'm reaching many of you in your homes, maybe after work, maybe you're at work, and delighted that you're joining us. So we are here to learn together about SADS conditions, sudden arrhythmia death syndromes, health conditions that cause sudden cardiac arrest and sudden death, often in young, healthy individuals, and sometimes without much warning. And so our job really is to educate and provide some knowledge for all of you impacted by these conditions. So welcome. Just going to share my slides here, which may or may not be happening. There we go. Hard to believe it's episode 23, just as it's hard to believe that it's already middle of September. That back to school feeling came upon us rather quickly this year. So definitely our executive director, Pam Husband, who started this idea, the SADS Foundation in Canada, many years ago, over 2 decades ago. And she's been very involved in getting the cardiomyopathy community engaged. So we're going to talk more about cardiomyopathy today. Of course, cardio, heart, and myopathy, muscle disease. So today is all about a heart muscle disease. And we have started our Think Cardiomyopathy campaign. So lots of opportunities to learn, also opportunities to donate and support what we do here at the SADS Foundation. Just a little housekeeping. Next month, we have a special guest who is going to come near the end of October, October 29th. Usually we're around the middle of the month, the third Tuesday, but we're making a little shift, maybe make it a bit more Halloween-like. So just, we'll remind you about the change in dates closer to the time. So very grateful for sponsors and very, very happy to see a growing list there. These companies have really committed their attention also to caring for SADS patients. So sudden arrhythmic death conditions they're not as common as some of the other conditions we hear about. So let's say a heart attack, or an osteoarthritis of your knee, or low back pain. But they're very impactful conditions, and it's very, very complicated biology that requires really dedicated treatments. And so some of these companies are working on these very complex and new therapies. So some of them are even into the field of genetic therapy. We had a session about that a few sessions ago, where we talked about gene therapy, which sounds like things from the future, but the future is now, as they say. And so thank you to our sponsors who really help us put on educational material, such as our webcast here, and also webinars, educational webinars, and those can be found on our website, I believe. So some really great educational material. As you know, I like to participate in a little bit of off the beaten path education. Last year, our focus was really on Canadian medical history. This year, we're trying to bring some facts about our SADS conditions. And here's just some reminders. And those of you who are regular participants, you'll remember that we had a little fun trivia contest towards the end of the year with a competition. So here's just some of the things we talked about: CPVT, arrhythmogenic cardiomyopathy. There's that word again. And some interesting history about long QT syndrome, which is, of course, one of the better known SADS conditions. And as I mentioned, we talked about gene therapy, and also talked a bit about a Canadian contribution to understanding hypertrophic cardiomyopathy. And so with that said, I'll give you this month's fun fact. Wolff-Parkinson-White is a rare cause of sudden cardiac arrest and can be associated with hypertrophic cardiomyopathy. I shouldn't call these fun facts. They are interesting facts. and very relevant to what we do. So Wolff-Parkinson-White, we often don't talk about Wolff-Parkinson-White because it's a bit different from some of the other SADS conditions. It's a bit more common than some of them, and can also be seen on a regular ECG. So you can see there's an ECG showing a delta wave, and some of these young patients have heart racing or episodes of tachycardia. But the reason for mentioning it today is we're going to talk about hypertrophic cardiomyopathy. And with that said, I'm delighted to be introducing our guest, Dr. Rafik Tadros, and he is well known to the Canadian and international SADS community. He's an electrophysiologist at the Cardiovascular Genetics Centre of the Montreal Heart Institute, which of course has a long history of very preeminent cardiologists in this field. He has also a PhD in cardiovascular physiology and is specifically trained in cardiovascular genetics and genomics. So he holds a Canada Research Chair in Translational Cardiovascular Genetics. So you're really expert in taking these inherited heart rhythm conditions right from bench to bedside, so understanding the mechanisms, the molecules, all the way to the patient. So let's bring Dr. Tadros into the studio, and really excited to talk today about hypertrophic cardiomyopathy. So welcome, Dr. Tadros.
Hi. Hi, everyone. Hi, Shu. It was great to be here and honored to be a guest speaker at the SADS Foundation, Canadian SADS Foundation podcast.
Well, thank you so much. And I'm probably going to call you Rafik, although Dr.
Please
Tadros is well earned. You have both a medical degree and a PhD. Tell us a little bit about how you ended up where you are. And I'm going to brag a little bit on your behalf because I know you to be very humble, but Dr. Tadros really is one of the international leaders in genetic studies in inherited heart rhythm conditions, especially some of the cardiomyopathy work he's done is absolutely internationally impactful. So how did you get here?
I mean, first, thank you for the kind introduction, Shu. Honestly, the Canadian community, SADS community and the Canadian genetic heart disease community is a very strong one, and I'm happy to be a small part of it. So to answer your question, I got interested in cardiac electrophysiology. So that's the electricity of the heart and the impact of the electricity of the heart on disease. When I was a trainee actually a medical student, a first-year medical student, got interested in the electricity of the heart and started to do research on the AV node, which is a small structure of the heart that conducts electricity from the top chambers, the atria, to the bottom chambers, the ventricles. And it ended up pursuing a PhD on that in that field, in physiology, or the normal functioning of the electrical system of the heart. And at that time, genetics was a big hype. There's a lot of interest and a lot of interesting discoveries and impactful discoveries. And I kind of switched from the physiology, understanding the mechanism of heart conduction in the heart, to the contribution of genetics in heart disease. And so got interested on the molecular cardiology. So the cardiology, of course, is the specialty of treating heart disease, and molecular cardiology is the interest of treating heart disease and understanding heart disease from a biology perspective. And this is how it started, and continued my training in internal medicine and cardiology and cardiac electrophysiology. So I do some procedures, defibrillators and some arrhythmia ablation. And then I pursued, and that time I pursued my interest in molecular cardiology and genetics. And so I completed a 2-year postdoctoral fellowship in Amsterdam, where a lot of the action is happening on the world scale in the field of cardiovascular genetics. And even though initially I was particularly interested in electrical heart disease, so arrhythmia, I kind of progressively shifted my interest to the cardiomyopathy. So understanding the genetic basis and the mechanism of cardiomyopathy for first better risk prediction, so identifying patients that are at risk of having adverse outcomes, so sudden death, cardiac arrest, requiring transplant, and also hopefully understanding better the biology of cardiomyopathy to develop new therapies that are targeting this pathophysiological mechanisms underlying the cardiomyopathies.
So quite a journey, and some important stops along the way, including, I remember when you were with our good friend Dr. Arthur Wilde in his program in Amsterdam, and of course he's been a guest that we were honored to have here. So let's now shift to what our main topic is today, which is hypertrophic cardiomyopathy, and of course Dr. Tadros has just co-chaired a very important document from the Canadian Journal, from the Canadian Cardiovascular Society in the Canadian Journal of Cardiology. So, and I've been reading this document. It really is an excellent overview of hypertrophic cardiomyopathy. So I thought we'd sort of walk through it a bit. Maybe you can start us off and just tell us a bit about the process, because coming up with this document is not a small feat. So I'm curious sort of how long it's been in the making and who all was on it.
Yes, I mean, so the process is indeed a long, lengthy process to make sure that the content represents the diversity of Canada and different provinces, East Coast to West Coast, the diversity of expertise. So hypertrophic cardiomyopathy is not a disease that is managed by a single specialty or a single person, but rather a disease that's managed by in an interdisciplinary program, at least for those patients with cardiomyopathy that are a bit more challenging or more severe. So that includes, medical geneticists for the genetic aspect, genetic counselors, pharmacists for the new therapies that we probably will discuss shortly, cardiac electrophysiologists, so specialists of the electricity of the heart and defibrillators, cardiovascular surgeons, because some patients with hypertrophic cardiomyopathy require heart surgery, what we call myectomy, interventional cardiologists, people that do interventions to treat obstruction in hypertrophic cardiomyopathy, and of course, imaging cardiologists that could, tell us more about the imaging aspect of cardiomyopathy. So the process is a lengthy process. It took us about 2 years, I would say. It's initiated by a proposal to the Canadian Cardiovascular Society that there's a lot going on in hypertrophic cardiomyopathy that we should, bring in an expert panel and discuss together what should be done and shouldn't be done in treating hypertrophic cardiomyopathy patients in Canada. So this proposal was done by my co-chair, Andrew Preen. And the proposal, of course, was accepted because the Canadian Cardiovascular Society, deemed or judged that the field requires an update to cardiovascular clinicians, so that we could ensure that patient care is optimal. And then we proposed members for the committee. Of course, we had a long list of committee members proposed to the Canadian Cardiovascular Society, because we think that there's a lot of people, a lot of experts in HCM in the country. And due to, I guess, feasibility issues, the Canadian Cardiovascular Society needed to select some committee members. And so we sat down, made a plan, and then each person drafted a section of the document based on their expertise. And of course, everyone reviewed the document and put it together. What we did in, I guess, different way this time is that we wanted to ensure that the pediatric community is well represented, that patients, young patients with hypertrophic cardiomyopathy would also benefit from this clinical practice update. And so we ensured to involve a leading person in pediatric HCM, Dr. Seema Mittal, from the Hospital for Sick Children in Toronto, Sick Kids. And so Dr. Mittal made sure that in every single section of the document that there was some comment on the pediatric patient and how this patient should be managed. So the particularities or specifics to the pediatric population. So that's how we did it. And then once the document was completed, it was submitted to the Guidelines Committee of the Canadian Cardiovascular Society to evaluate its content and make sure that it's accurate and make sure that it's balanced and it's not biased. And so once it was approved, it was published in the Canadian Journal of Cardiology. It was just published in the paper, I think last month, a few weeks ago. Yeah. So.
Yeah, it's literally hot off the press, and I wasn't sort of trying to torture poor Dr. Tadros to make him relive the journey. I just really wanted our viewers to appreciate, first of all, how that it's a lot of work to produce something like this, but also the quality of the data is very high because it really is national. National representation, goes through a lot of peer review. There's a lot of teamwork and very diverse teams. So these documents are a very good source of information, and this one's very up to date. And I encourage people, especially the allied professionals, the family physicians, pharmacists, and genetic counselors who are on the call today, to find this, and it's got a beautiful layout, lots of good graphics as well. So I think this will be a great resource for the medical community. So let's start. We've kind of been saying hypertrophic cardiomyopathy, and you start out really with saying what is hypertrophic cardiomyopathy and what isn't hypertrophic cardiomyopathy. So let's just make sure that let's just focus on what is hypertrophic cardiomyopathy in the context that we're discussing.
So hypertrophic cardiomyopathy is a type of cardiomyopathy. As Dr. Senetani explained, cardiomyopathy literally means disease of the heart muscle. So it's a primary disease of the heart muscle, and hypertrophic is the type of cardiomyopathy where the muscle or the heart muscle is thickened, and it's not thickened secondarily to a systemic process like or high blood pressure, for example. Because if you have hypertension, you could also develop a thickened heart, and this is maybe hypertrophic cardiomyopathy. It can also be just a reflex or a reaction to the increase in blood pressure. And so hypertrophic cardiomyopathy is a primary disease of the heart muscle that is characterized by thickening of the heart muscle. And the measures, the exact measures or cutoffs or thresholds are in the document, and I don't want to go into the details unless Dr. Senetani wants me to. But of course the measures depend on patient size. So in the pediatric population, we cannot use the same thresholds as in the adult population because the hearts are smaller, right? So the threshold to diagnose hypertrophic cardiomyopathy in an adult is not the same as in the child. And it's important when a patient has a thickened heart muscle to make sure they don't have other diseases that could cause thickened heart muscle that is not hypertrophic cardiomyopathy. So there's a workup that needs to be done, and that includes genetic testing to make sure there's no other disease that causes thickening of the heart muscle. And some of those diseases, like Fabry's, for example, Fabry's disease is not hypertrophic cardiomyopathy, but could present like hypertrophic cardiomyopathy. And these are diseases that could be treatable with enzyme supplementation.
And the differentiation between high blood pressure or hypertension is such a common condition in our population, particularly in our aging population, and so important to recognize that type of load on the heart looks quite different. But sometimes you really do need the experts, and I notice that increasingly across the country there are hypertrophic cardiomyopathy clinics. In part arising because of new treatments that we're going to talk about. But it really is a complex disease because it combines the heart muscle, so the structure, but also an electrical component and a lot of symptoms. So you've mentioned the genetics. What are the main sort of causes of the hypertrophic cardiomyopathy in terms of the genetics? And again, we won't make you go through an exhaustive list of all the genes, but if you could just educate us a little bit on what is going what's going on to cause this heart muscle to be so thick?
Yeah. So this is an area of interest of mine and general, what drives the hypertrophy, what causes the thickening of the heart muscle. And we now know that in about a third of patients, this is caused by what we call mutations, so abnormalities in the sequence of the gene. So genes are coded in our DNA, and each gene is basically the instruction to make a protein. And so genes involved in hypertrophic cardiomyopathy are generally coding for proteins that make what we call the cardiac sarcomere, or the apparatus that makes the muscle contract. And so defective genes of the cardiac sarcomere increases the strength of the sarcomere and makes the muscle hypercontractile, so meaning that the heart muscle, instead of contracting normally, it is contracting a bit more than normal. So it's a hypercontractile disease, meaning the heart has increased contraction or contractility. And so this increase in contractility is what drives hypertrophy, is what drives thickening of the heart muscle. So that's a third of the patients with hypertrophic cardiomyopathy have an identified genetic defect in those genes that code for the cardiac sarcomere. In 2/3 of patients, the genetic test would be negative. It would not show a defective gene that encodes for the cardiac sarcomere. And those patients that have hypertrophic cardiomyopathy actually do have what we call polygenic or multifactorial hypertrophic cardiomyopathy, where instead of a single defective gene causing the disease, it's actually a multiple small genetic variants, each with a very small risk increasing effect, together with some comorbidities like high blood pressure, which together drive the hypertrophic cardiomyopathy. So in hypertrophic cardiomyopathy, from a genetic perspective, a third, there's a mutation identified by a genetic test, so a blood test that looks at the gene, and 2/3 that is more complex. It doesn't exclude hypertrophic cardiomyopathy, but it tells us that it's a more complex disease. Not complex in the management, but complex in terms of what causes it.
And so that's really important learning for us, because some of the conditions, let's say again long QT syndrome, that we have some familiarity with, genetic tests, if it's a clear case and it's been well evaluated and diagnosed, the genetic test may be positive in as many as 80%. CPVT, catecholaminergic polymorphic ventricular tachycardia, again, we're going to find a genetic find maybe in 2/3 of cases. So having 1/3 is a relatively small number, but really, again, this polygenic, where multiple genes are contributing, again, reflects the complexity of what we're dealing with. Now, are people accessing these polygenic diagnoses outside of a research setting? So let's say I have hypertrophic cardiomyopathy and I go through a relatively standard genetic test that doesn't find something. Are there people then, can one get polygenic tests where you look at your whole DNA?
Yeah, so it's a good question, Shun. It's a work in progress. The short answer is polygenic risk at the time being is more in a research setting. So we know that patients that have hypertrophic cardiomyopathy with a negative genetic test, we know that they have a polygenic disease, but we're not there yet in quantitating or measuring this polygenic risk. It will come, but we're not there yet. It's more in a research setting.
And of course, one of the things that's challenging then is, in some of our conditions, if there is a genetic marker, one can test family members for the genetic marker and track that. If you don't have a genetic marker, then sometimes people are going to the clinic, every 1 or 2 years and getting checked to see if their tests have changed, their ECG or echocardiograms, those kind of things. So it's fairly nuanced genetic testing. So yeah. Let's say, okay, I now have, I've come in, with hypertrophic cardiomyopathy, what are some of the ways that these people, especially young people, are presenting? Not all of them are presenting with cardiac arrest. What are sort of some common pathways into your clinic with this diagnosis?
Yeah. So, I mean, three typical presentation, if we are to classify them. So the first presentation is the incidental findings. So these are patients that go to their doctor for no specific reason or an unrelated reason. The doctor examines them and then hears a murmur, a heart murmur, a turbulence of flow. So that could be a sign of hypertrophic cardiomyopathy. Another incidental finding is an abnormal ECG. So the patient, undergoes an ECG for a new job, for insurability, because he went to the emergency room for unrelated symptoms, and they get an ECG, and the ECG can be normal. So this is what we call the incidental finding of hypertrophic cardiomyopathy, either a murmur or an ECG. The second group of patients are diagnosed in the context of family screening. So patients go to their primary care physician or nurse practitioner and said, well, my father, my mother, my brother, my uncle had a diagnosis of hypertrophic cardiomyopathy, and they recommended that the relatives undergo screening with cardiac ultrasound and an ECG. And sometimes, of course, in these patients, we diagnose hypertrophic cardiomyopathy. So that's the second class or presentation type of presentation, diagnosis in the context of family screening. And the third context is symptoms. So the symptoms can be chest pain, a really diverse type of symptoms, could be chest pain, shortness of breath, feeling dizzy when they exercise on exertion, so dizziness on exertion, or literally syncope or passing out. And more extremely, of course, some patients could present with a cardiac arrest or even sudden cardiac death, and the diagnosis can be made through the pathologist investigation. And so these are the three typical contexts where we see patient diagnosed with hypertrophic cardiomyopathy, either incidental finding, a murmur, an abnormal ECG in someone that is asymptomatic, no symptoms, diagnosed in the context of family screening, or diagnosed in the context of symptoms, and the symptoms could go from chest pain, shortness of breath, palpitations, dizzy spells, passing out, or literally a cardiac arrest.
And I'll just sort of put things a bit into context. Heart murmurs, for example, are very common in children, especially. So, and hypertrophic cardiomyopathy occurs in approximately 1 in 500. So certainly not every child with a heart murmur has hypertrophic cardiomyopathy. And similarly, people that are experiencing shortness of breath while exercising, most of you will not have hypertrophic cardiomyopathy. So it's always important to take it into the context of your family history, of course. Now, there's another very important, you mentioned the pathologists, and I just want to point out that the diagnosis of hypertrophic cardiomyopathy really requires a very skilled pathologist to be involved. And the heart is often found to be enlarged, and an enlarged heart is not the same as a hypertrophied or a thickened heart. So there are people that hear that term, oh, the heart was enlarged, but really what we're talking about is a very specific diagnosis where the heart muscle is abnormally thick in a very abnormal pattern, often due to genetic factors. So some of the presentations, of course, are going to determine what we have to do. We talked a little bit about there can be obstruction. So if the heart muscle is so thick that the blood flow is not adequate, then you may need an operation or a cardiac catheterization. What are you doing with your patients that are coming in who are relatively symptom free? So either family screening or incidental finding, they don't have symptoms, but they have hypertrophic cardiomyopathy. What kind of advice are you giving them? Specific treatments which is the largest group of these patients. that are found incidentally or are are less affected family members?
Yeah, that's a very good question. I think it's important to recognize, as you mentioned, Shu, that most patients with cardiomyopathy would not have severe outcomes, cardiac arrest and stroke and so on. And so it's important to recognize this. So for the asymptomatic patient, a patient that doesn't feel anything and where cardiomyopathy is identified either in the context of family screening or incidentally diagnosed on cardiac imaging following a murmur or an abnormal ECG, it's important for these patients to know that there is no approved therapy to modify the progression of disease, or not yet. Eventually we may have, but for now, patients with a thickened heart, if they don't have symptoms, there's nothing that we could give them. There's no drug that we can give them to prevent progression of the disease. And as a matter of fact, the progression of the disease is not something that's easily quantified. This is something that patients ask me all the time. If my septum or my muscle, will it thicken more over time or not? And generally speaking, in the adult population, it doesn't progress that much. And so we don't have therapies to give patients to prevent progression if the disease is to progress. What we should do in the asymptomatic patients, so patients who have the disease but don't have any symptoms, is to make sure that we look or evaluate the risk of having adverse outcomes. And the adverse outcomes that we should look at in the asymptomatic and symptomatic patients are 1, stroke, 2, cardiac arrest and sudden death. So stroke is generally mediated through atrial fibrillation. So atrial fibrillation is one of the complications of hypertrophic cardiomyopathy. It's an arrhythmia that is benign from a heart perspective, but it increases risk of stroke. And so we should screen for atrial fibrillation in all patients with hypertrophic cardiomyopathy by using prolonged ambulatory monitoring. So that's an ECG, not the 10-second ECG that you get at the physician's office, doctor's office, but it's the ECG that's recorded over 24 hours or 48 hours or a week or 2 weeks. So this is a patch that we put on the skin and records the ECG for at least 24 hours or 48 hours. So this is something that we recommend as part of the consensus statement of the Canadian Cardiovascular Society, is that all patients with hypertrophic cardiomyopathy should have screening for atrial fibrillation using at least a 24-hour monitor every year, at least. The second thing that we should look for in asymptomatic patients and symptomatic patients is evaluate the risk of having a cardiac arrest. And so there's, without going into the details, there's different risk markers that we should look for on imaging and the symptoms and family history. So these are, and on the ambulatory Holter or ECG monitoring. And these could be indications that the patient is at increased risk of sudden cardiac death and cardiac arrest. And for a small subgroup of patients with hypertrophic cardiomyopathies, we would recommend implanting a cardiac defibrillator to prevent sudden cardiac death whenever we judge the risk is sufficiently high to justify this procedure, which is not without consequences or risk, of course.
And, really important to, again, make sure that the diagnosis is correct, managed by an expert team. We don't think most people need defibrillators, but if you are in the higher risk, that might be something that is necessary. Let's now turn to our therapies. You've mentioned some therapies in the last few years have been very exciting. From my understanding, really some of the first truly mechanism-based treatments in our SADS field. So maybe take us through a bit of that, particularly some of the new medications that have, I would say, have changed the hypertrophic cardiomyopathy clinics, certainly out here. Tell us a bit about that.
Yeah, so absolutely. So for the time being, the only therapy that is approved in Canada are what we call a new class of drugs that we call the cardiac myosin inhibitors. What does that mean? The cardiac is heart. Myosin is the protein that makes the muscle contract, and inhibitor means that it's a blocker. So these are medication or drugs that were developed to block the contractile activity of the heart. Not completely, of course, because the heart needs to pump, but at least decrease the contractile activity of the heart. And this relates to what I mentioned earlier, that the mechanism of hypertrophic cardiomyopathy is really increase in the contractile force of the heart, where the heart becomes have increased contractility, but also becomes rigid because of this hyperactive myosin. And so these medication, there's one that is approved and potentially another one that hopefully will be approved soon. So the one that's approved is what we call mavacamten, or Camzyos is the commercial name. So these are medications. This is a medication that was proven to be effective in improving symptoms in patients with hypertrophic cardiomyopathy that have symptoms and that have obstruction inside their hearts. Okay, so obstructive hypertrophic cardiomyopathy is a type of hypertrophic cardiomyopathy where, because of the thickened heart muscle and the increased force, there's contraction, there's obstruction of the blood flow inside the heart. And so in these patients that have obstructive hypertrophic cardiomyopathy, that have symptoms that are limited in their daily lives, we could prescribe this new medication, what we call mavacamten or Camzyos, to improve their symptoms. So this is the only thing that has been shown for now in a robust clinical trial, a very well done study, a research study, where patients with obstructive hypertrophic cardiomyopathy and symptoms were randomized to the new drug, mavacamten, versus placebo. And it was demonstrated that patients that took mavacamten have improved symptoms and exercise capacity. So this is the only thing that has been proven, is improved symptoms. The drug has not yet been shown to be effective in preventing progression of disease or development of the disease in someone that might be at risk because they're a gene carrier, for example. So this may be coming in the future. For the time being, mavacamten or cardiac myosin inhibitors are prescribed only to control symptoms. When we look back to the development of the drug, as a matter of fact, actually, the story is interesting because we're in Canada, but the development of mavacamten actually was a paper that was published many years ago now, almost a decade ago now, where the researcher studied the first mutation that was published in hypertrophic cardiomyopathy. And interestingly, this mutation is actually in a French-Canadian family, that some of which actually are still followed in our institution. It was not our discovery, it was the Boston group, Harvard, making this discovery. But this specific mutation, which was the first to be described in hypertrophic cardiomyopathy, the scientists at that time developed a mouse model with this specific mutation, and they showed that mice develop hypertrophic cardiomyopathy. And if you block the myosin or the cardiac myosin with mavacamten, you actually prevent the mice from developing hypertrophic cardiomyopathy. And so the animal model is actually very exciting. It tells us that the drug might not only improve symptoms, but might also prevent the development of the disease in someone at risk. Now, these are animal models, animal research. It's not in the human. In the human, the only thing that has been shown for now are improvement of symptoms, but not prevention of progression of the disease. I'm being asked to comment on when should patients be prescribed this new drug. Sorry, I'll hang up this. So when patients should be prescribed this new drug versus undergo an invasive therapy for obstructive hypertrophic cardiomyopathy. Basically, why mavacamten, Camzyos, the new drug, versus the traditional approaches involving removing part of the septum, either through a catheter or open heart surgery. And really, it's a patient preference mostly. So definitely in someone that may be at high risk of complication of a procedure, then of course a medication, it would be the most appropriate option. In patient that has a low risk of complication from heart surgery, then potentially the myectomy or the surgery may be preferable in terms of the long-term benefit as opposed to the mavacamten use, which should be pursued. It's not a drug that we take for 6 months a year and then we stop it and then we're cured. It's not like an antibiotic that we take for an infection, right? It's a drug that we should take over a long period of time to control symptoms in someone that has obstructive hypertrophic cardiomyopathy that has symptoms. And so sometimes it's a patient choice, and the physician or the HCM expert is there to help guide the patient as to whether a pharmacological approach or a drug approach is preferred versus a more invasive approach using surgery or a catheter approach. So this is kind of a short answer. You should discuss this with your treating physician. Obviously, more and more with our experience, we tend to try or attempt or give a trial of mavacamten first before sending the patient for invasive therapy. But some patients prefer having the therapy, the surgery done, and then they don't need to take mavacamten in the long term. So it's a personal choice.
I think the mavacamten story is an exciting one, and as you say, more to come, because the whole prevention aspect, does it have a role in prevention as well? It's a significant impact on the patient's medical follow-ups. There's a lot more monitoring and regular echocardiograms, because you are changing the contraction of the heart. So really a fundamental function. I'd like to spend a couple of minutes, we have a couple of minutes left, and ask you the hard stuff. The hypertrophic cardiomyopathy is one of the most common causes of cardiac arrest in athletes, and so there are some very high-profile cases of cardiac arrest and even sudden death in young athletes. What's your approach to exercise participation in your athletes with hypertrophic cardiomyopathy?
Yeah, the bottom line, the approach should be personalized. The historical answer for hypertrophic cardiomyopathy would be a patient with hypertrophic cardiomyopathy should not have moderate to high level exercise, because people were worried about the risk of sudden cardiac death. Now, this is now completely changed based on new data that shows that moderate, even to high level exercise, and even competitive vigorous exercise, was not associated with increased risk of death, sudden cardiac death, or cardiac arrest. And so this is data that is relatively fresh, relatively new, and does make us change our mindset in terms of counseling the athlete with hypertrophic cardiomyopathy and whether they should or should not continue exercising. The bottom line is, or for all patients with hypertrophic cardiomyopathy that are stable, that didn't just have a cardiac arrest or don't have uncontrolled obstruction, for example. So stable patient with hypertrophic cardiomyopathy should probably have moderate level exercise like everyone else, and this has been shown to be beneficial. In terms of higher level of exercise or more vigorous exercise, the approach should be personalized. But we are more and more liberal and permissive in terms of allowing patients with hypertrophic cardiomyopathy to exercise more vigorously, and even some participate in competitive sports. But again, the approach should be personalized, should involve the HCM expert, the patient, their parents if they're children, potentially the school or the club or the whatever their working is, and take a joint decision altogether to make sure everyone is aware of the potential risk of cardiac arrest on the field in competitive vigorous exercise, and the potential benefit as well. But the bottom line is everyone should exercise moderately unless they're unstable. And some patients may also be allowed to exercise more vigorously, even in competitive sports.
Yeah, no, thank you. I completely agree. And there are some real health benefits shown in research studies to the hypertrophic cardiomyopathy patients, where some of the health parameters improved with exercise programs. So Dr. Tadros, we are unfortunately at time. There's so much good information shared by you today, and in your document. Congratulations to you and the and the multidisciplinary team. It really is an excellent resource, and it's always a pleasure to speak to you. Your research in the field is really incredible, and I've enjoyed watching it unfold. I did neglect to mention that Dr. Tadros is also a member of the Canadian SADS Foundation Medical Advisory Board, the organization that's in the background helping guide the society in some of its decisions around content and information. So thank you so much, and I will look forward to speaking with you again as your research programs develop.
Thank you. Thank you for your invitation. I really enjoyed it.
Always a wonderful conversation, and he's an incredibly thoughtful clinician and researcher. So great answers to hard questions. I will wrap up with just a couple of comments. We're excited about an in-person meeting hosted by our good friends in the U.S., the SADS Foundation U.S. In Chicago in early November. And that conference is an in-person meeting, and it looks like great topics lined up. So check that out. And certainly think about going to our website and seeing what's been happening there on the educational front and the content. Consider making a donation if you enjoy our educational programs and our advocacy. Just a reminder, our session next month will be October 29th, so not the usual cadence, and we will look forward to seeing you then. Have a great week.